Good morning. I'm Bob Stolting, and as president of the Anesthesia Patient Safety Foundation, I am pleased to welcome you to the 2016 ASA APSF Ellison C. Patient Safety Memorial Lecture. This honorary lecture will be delivered by Dr. Alexander A. Hannenberg. Dr. Hannenberg has chosen as his topic, Safety Beyond Our Borders, Different but the Same. The Ellison C. Pierce Patient Safety Memorial Lecture was established by the American Society of Anesthesiologists and the Anesthesia Patient Safety Foundation to recognize and sustain the memory of Ellison C. G. Pierce, the founding president of APSF and an ASA president in 1984. It was Dr. Pierce's vision and unwavering commitment to anesthesia patient safety that led to the formation of APSF in 1985 as the first medical specialty foundation devoted solely to patient safety. Today, the medical specialty of anesthesiology, ASA, and APSF are recognized as pioneers in advancing and advocating for patient safety as APSF strives to attain its vision that no patient shall be harmed by anesthesia. Now, Dr. Hannenberg is a native of Brooklyn, a graduate of Tufts University School of Medicine. He completed his anesthesia residency at Harvard's Beth Israel Hospital. Currently, Dr. Hannenberg is a clinical professor of anesthesiology at Tufts University School of Medicine in Boston and serves as the associate chair of anesthesia at the Newton Wellesley Hospital in Newton, Massachusetts, a position he has held since 1991. Dr. Hannenberg began his volunteerism with ASA as a delegate for Massachusetts in 1987. In 2004, ASA created a new office position, the Vice President for Professional Affairs and Oversight of Activities in Governmental Affairs, Economics, Practice Management, Patient Safety, and Professional Standards. Dr. Hannenberg was the first individual elected to this position, which he held for 4 years. He has led ASA's efforts to create performance measures for Medicare's Physician Quality Program and to establish the Anesthesia Quality Institute and its National Anesthesia Clinical Outcomes Registry. In 2010, Dr. Hannenberg was elected ASA's 74th president. Dr. Hannenberg is a founding member of the Lifebox Foundation, a global health organization focused on improving surgical patient safety worldwide. Recently, he founded and became president of the ASA Charitable Foundation that leads the ASA campaign for Lifebox. Dr. Hannenberg and his acclaimed international contributions for advocating worldwide initiatives to enhance anesthesia patient safety make him an outstanding selection to deliver the 2016 ASA APSF Ellison C. Pierce Patient Safety Memorial Lecture. His topic for this honorary lecture, Safety Beyond Our Borders, Different but the Same, is a fitting tribute to the memory and contributions of APSF's founding president, Dr. Ellison C. Pierce. Please join me in welcoming Dr. Hannenberg.
Very well done. Thank you. Thank you, Bob, and good morning to you all. I'm enormously grateful and honored to have been chosen by the Foundation to present this Ellison Pierce Patient Safety. My topic for this morning is Patient Safety Beyond Our Borders, Different but the Same. I hope to explore with you some of the major safety challenges faced in low-resource settings that threaten the lives of tens of thousands of surgical patients daily. And many of these challenges have their parallels in the patient safety work done by APSF and by each of us in our practices on a regular basis. As I look at our audience this morning, I realize that there are a good number of our colleagues here born after Dr. Pierce's ASA presidency and the creation of the Anesthesia Patient Safety Foundation. In the next few moments, I pledge to do everything I can to be sure that not a soul leaves this room without a deep appreciation of the contributions made by the giant we honor with this lecture. Dr. Ellison Pierce was an anesthesiologist practicing in Boston for nearly all his career. He was known nearly universally as Jeep, a childhood nickname. I suspect he was only addressed as Ellison by telemarketers. He was chairman of anesthesiology at what was then the New England Deaconess Hospital, and during that tenure served as president of the American Society of Anesthesiologists in 1984. Now, that was a time at which the cost and the availability of professional liability insurance for physicians had reached crisis proportions. And while most medical specialties pointed fingers at the legal profession, he aptly recognized that there were preventable deaths occurring in anesthesia and committed the specialty to eradicating avoidable patient injury. Thus, the APSF vision that no patient be harmed by anesthesia. He obviously did not do this alone and had the support of very able and creative colleagues, including Jeff Cooper and others with whom he founded the APSF. But it was Jeep's use of the bully pulpit of the ASA presidency that made it possible for anesthesiology to take the lead among medical specialties in addressing safety concerns. I once asked him if the expression patient safety, which is now so much part of our lexicon, had originated with him, and he didn't deny it. Anesthesiologists today take great pride in seeing our specialty singled out by the Institute of Medicine and others as the most successful in improving the quality and safety of our practice. It would not be an exaggeration to say that this distinction comes principally and directly from the contributions of Dr. Pierce. He received many honors during his career for this work, including ASA's Distinguished Service Award in 1996. So the opportunity to present this lecture in his memory is of particular significance to me because Jeep was an unfaltering source of encouragement throughout my career, and we became good friends as a result. The photo here was taken in 2009 on the occasion of a reception in Boston recognizing my installation as ASA president that year. As you can see from the picture, Jeep was quite frail by that time and made special arrangements with a colleague to drive him to and from the event. The effort he made to be by my side was unforgettably generous, and I regard this morning's presentation as an opportunity not only to honor his work, but to thank him for all that he'd done for me personally. Dr. Stolting, his successor as president of APSF, will be stepping down from that position this year and will be succeeded by last year's Pierce lecturer and my dear friend, Dr. Mark Warner. APSF is so amazingly fortunate to have had leaders of this caliber. The entire specialty and patients everywhere owe them an incalculable debt of thanks. As noted in the introduction, I am a founding trustee of the Lifebox Foundation, created by a remarkable group of individuals to improve the safety of surgery globally. Most of what I know about global health is a result of my collaboration with those listed and others who have made what I consider my extended fellowship enormously stimulating, and I am amazingly privileged to have had tutors of this caliber. Of course, this morning's errors are my own. The APSF and Lifebox have really closely aligned missions, though focused in different parts of the world. And Lifebox takes perhaps a slightly more holistic approach to the factors leading to preventable injury of surgical patients, recently launching an initiative to control surgical site infections, for example. But since it is evident that a majority of patient injuries in the developing world today relate to anesthesia care, the focus of Lifebox in its first 5 years has been on spreading oximetry and safe anesthesia practices. So it would be good to start with an overview of the crisis facing patients with surgical disease in the developing world. Simply put, too many of those needing surgical care lack access to it, and those who do get needed operations face an extraordinary risk of complications and death. The Lancet Commission on Global Surgery, about which you'll hear a good deal this morning, estimates those numbers at 5 billion without access and 7 million dead or disabled annually from complications of surgery. The exhaustive, see, Mark, it isn't that straightforward. The exhaustive, thoughtful, and comprehensive Lancet Commission report issued in the spring of 2015 was one of a rapid-fire series of events that brought surgical care out of the shadows of global health, which has historically focused heavily on infectious and communicable disease. Magically, within weeks, the World Health Assembly passed a resolution identifying surgery as a basic element of essential health care for the first time. And nearly simultaneously, the World Bank published a new volume in its Disease Control Priorities series that addressed essential surgery. I am very hopeful that this remarkable trifecta of global events will ultimately lead to improvements in both access and surgery. Indeed, even before the spring of global surgery, as I like to call it, we were witnessing a dramatic growth in the number of surgical procedures performed worldwide, an approximately 30% increase between 2004 and 2012, as shown in a report by fellow Lifebox trustee Tom Weiser. Surgery has now become a more frequent event worldwide than childbirth. The troubling question here is whether the growth we have witnessed and the improvement in access that we seek will lead to a proportional increase in the numbers killed or disabled. In this light, it is clear that the linkage of improved access and improved safety is an absolute imperative. We can do much better than by proliferating unsafe surgery. To give you an idea of the kinds of risks faced by millions of patients, this graphic summarizes data from 4 small series reported from Africa. And understand that some of these reports are now dated and all come from places with very limited health data systems. We will come back to the issue of outcomes measurement soon, but be that as it may, these reports suggest avoidable mortality 100 or 1,000 times the rate we face in our communities. So it is understandable, but nonetheless tragic, that a patient in Togo or Malawi might fear surgery more than he fears a lifetime of pain and disability. You may recall that we heard a little bit about Togo in Alan Merry's 2013 Ellison Pierce lecture. Now let me pause here for a moment to introduce you to the Human Development Index, a valuable tool used among other things, quantifying disparities in surgical and anesthetic outcomes. Published since 1990 by the United Nations Development Program, the HDI is a formulaic amalgamation of life expectancy, education, and income that has undergone multiple revisions and refinements over the years. The extremes of the scale for 2014 showed Norway highest at 0.944 and Niger lowest at 0.348. For those of you interested, the United States was 8th at 0.915. So the graphic here shows the HDI data from 2014, and you'll note that the countries whose mortality data we just saw all have human development indices of 0.5 or lower. In a 2012 Lancet paper, Bainbridge analyzed 87 reports on the frequency of anesthetic and surgical events, including mortality solely related to anesthesia, mortality in which anesthesia was a contributing factor, total perioperative mortality, all measured in the immediate operative and postoperative period, and the frequency of cardiac arrest. The Bainbridge series included 19 papers from low HDI settings compiled over multiple decades, and he used 0.8 as the break point between high and low HDI nations. For another point of reference, 0.8 is the HDI of Belarus, Russia, and Montenegro. So this figure from Bainbridge's data shows the most recent 2-decade period and the very dramatic disparities in rates of mortality and critical events. The rates of these events in the low HDI settings range from 2 to 5 times the frequency of those events in high HDI settings, with the most dramatic disparities evident in anesthesia sole cause and anesthesia contributory mortality. Another disturbing finding from the Bainbridge report is that anesthesia-related mortality has not noticeably improved over the decades in the low resource settings. Here I have charted, using Bainbridge's data where available, the rates for 3 time periods: prior to 1970, the 1970s and 80s, and the 1990s and 2000s. The red represents data from the low HDI settings and the blue from the high HDI countries. And you can see that the alarming gap in anesthesia events persists or even widens over these intervals. Interestingly, this does not appear to be the case for all-cause perioperative mortality, suggesting that unsafe anesthesia lags improvements in other aspects of surgical care and thus must remain a priority target. This phenomenon actually seems to me to be the inverse of the last generation's experience in high-income nations, where anesthesia improvements have led others. Now, if the expression health disparities sounds familiar, it should. This topic has been a potent factor in the politics of American healthcare reform. Government, insurers, universities, and communities are deeply committed to achieving health equity for our nation across income groups and across races. In this figure, you can see that even the most common chronic and acute illnesses occur more frequently in low-income Americans than in those with incomes over $90,000 annually. This is most notably true for depression, but dramatic gaps also exist in the precursors of premature cardiovascular death, such as hypertension, diabetes, and obesity. Therefore, it will not be surprising that the differences in life expectancy among Americans across the income spectrum amounts to 6.5 years. Now, I frequently noted along the way that our capacity to measure health outcomes generally and perioperative outcomes specifically in the poor corners of the world is severely limited. Medical records are often primitive or non-existent, and the wherewithal to do the necessary analytics is lacking in the face of the day-to-day demands of delivering care in austere conditions. All the more credit to the authors of the 4 African reports I cited early on. This is also an area in which universities in the US and elsewhere are making important contributions. But one of the key features of the World Health Assembly resolution approved in 2015 was a commitment to a global standard of reporting perioperative mortality rate. Now, the inclusion of this item in the WHO resolution, like much work in government and public policy, was not without controversy and required effective advocacy. And ASA, being no stranger to political advocacy, played a role alongside the World Federation of Societies of Anesthesiologists and other groups. Here you see ASA past President J.P. Abenstein, fresh from battle at the 2015 World Health Assembly in Geneva with Drs. Janneke Mellon-Olsen, Kelly McQueen, and David Wilkinson. So this WHA resolution places the influence of the World Health Organization behind the recommendation of the Lancet Commission on Global Surgery, which set a goal of reporting perioperative mortality in 80% of UN member states by 2020 and by 100% by the following decade. And if you believe that you cannot improve what you cannot measure, you will recognize this as an enormously positive step. And clearly, our colleagues in Africa and elsewhere themselves strongly embrace this concept, as evidenced by the very ambitious range of clinical registry projects emerging. Projects that face substantial obstacles in achieving the potential we've seen in NSQIP or the Society of Thoracic Surgeons registry projects. These obstacles are not unfamiliar, especially to those who have worked to create measures of anesthesiology practice. But one thing is clear, it's a long road, but if you never start, you'll never finish, and these African registry pioneers obviously realize that. In our own clinical registry work, and because of the increasingly aggressive emphasis on outcomes measure in government programs and from other purchasers of health services, some of which you heard about from Professor Porter, we are under pressure to find reliable, relevant, accurate measures that are somehow immune to gaming, are fair, and whose maintenance does not drain resources from patient care. There is no shortage of well-founded criticism of the reporting programs operated by Medicare, and yes, even by ASA. As simple as it sounds, implementing a worthwhile measurement of perioperative mortality is fraught with difficulty and will inevitably be subject to the same criticisms as the systems with which we now live. In this context, again, the fortitude of those African registry pioneers is awe-inspiring. The opportunity for misadventure in measurement even of something that is superficially quite black and white, like mortality, was described in Bob Legacy's 2002 report reviewing the literature on anesthesia outcomes. There he highlighted the immense variation in the data, even when contemporaneous reports were clustered, and pointed out the underlying absence of a common vocabulary. The figure here is his control chart on which 23 anesthesia mortality rates reported between 1955 and 1992 are displayed, with about half of the data points falling outside the control limits. Notably, all of the data were from high HDI settings, save 2, so the heterogeneity of the results is not likely to be based on the health disparities I discussed a few moments ago. I think I've made the case that notwithstanding the profound limitations in the data set, that there is significant and tragic excess risk associated with surgery in low-resource settings, and that much of that risk is rooted in unsafe anesthesia. I would like to spend some time discussing a few drivers of the excess risk, recognizing that time permits only a brief comment on a few selected dimensions of the problem, namely inadequate teamwork and communication, inadequate workforce, and inadequate material resources. Ask the principal developers of the World Health Organization Surgical Safety Checklist about the most essential purpose of the checklist, and they will reply that it is meant first and foremost to be a tool to promote teamwork and communication. It demands several conversations among all members of the surgical team, believing that forcing these discussions into routine practice will not only catch errors and omissions, but also increase the likelihood of effective collaboration when faults in the perioperative process actually do occur. You will recall that the trial of this checklist impact, published in the New England Journal of Medicine in 2009, studied its implementation in 8 sites, 4 rich and 4 poor. Achieving acceptance of its use, getting meaningful use beyond ticking boxes, and most of all, sustaining use, especially in low-resource settings, has been vexingly difficult. All of these things require changing practice and culture, and especially overcoming the barriers of professional hierarchy. This takes more than a printer and a thumbtack. Mary Dixon Woods is a medical sociologist and implementation scientist at the University of Leicester in the UK, who has a long-standing interest in medical safety innovations. She published extensively on the backstory of Peter Pronavos' Keystone Project on central line infections in Michigan. She and her colleagues produced 2 studies in 2014 and 2015, using structured interviews to learn what hospital staff members thought were the barriers to quality and safety in their institutions. The 2004 paper focused on Britain's National Health Service, and the 2005 publication came from work in East Africa. You can see why the title of the African paper, "Why is Patient Safety So Hard in Low-Income Countries," caught my eye. You can also see from my bulleted list of key findings how the barriers to safe care identified in the staff interviews are remarkably similar in the 2 settings. In the narrative of the African study, the authors comment, quote, "By demonstrating a remarkable symmetry with the accounts of staff in high-income countries, these accounts suggest that the origins and solutions to patient safety problems are likely to be similar everywhere and are rooted in human factors, resources, cultures, and behaviors." American culture doesn't seem to protect us against these barriers to communication, however informal and clubby our operating rooms may seem. This chart is made from the results of a survey of operating room nurses in 60 U.S. Catholic hospitals, in which the nurses were asked to rate their ability to communicate openly and collaborate with their perioperative colleagues. As you can see, the rankings precisely follow the professional hierarchy of the operating room. The nurses perceived effective communication with surgeons less than half the time, and anesthesia providers didn't fare much better. The environment that's required for safe patient care apparently doesn't occur naturally, can't be taken for granted, and thus demands a dedicated effort to create and maintain it. The work of Pronovost, Gowandi, and others offer proof that even the greatest ideas don't implement themselves. This particular survey of hand-washing practice comes from Saskatchewan, but really could be from anywhere. This is an example of a practice with indisputable evidence, trivial cost, no risk, that isn't even time-consuming, yet fewer than half of the physicians in this survey had made it their practice. Now, the language I just used to describe hand-washing is exactly the way I describe the safe surgery checklist. And the results, when you really look at effective use, are not that different. So 2 years ago, I had never heard of implementation science as a discipline, but I've come to believe that the field has much to offer us. It has matured to a point of having not only its own journal pictured here, but its own funding track at the National Institutes of Health. And you may have caught the fact that a few moments ago I referred to Mary Dixon Woods as an implementation scientist. Those of us interested in creating change would do well to pay attention to the output of the pioneers in this young discipline. The implementation scientist's dissection of a public sanitation project in rural India is stunningly eye-opening. In that Gates-funded project, thousands and thousands of toilets were installed in remote villages without any impact on water contamination or infectious diarrhea and its sequelae. The implementation scientists tell us why. I'd like to turn now to the problems of an inadequate healthcare workforce as a contributing factor to preventable harm. This is a figure from a report published by Gerald Dubowitz of UCSF a few years ago that shows the population of physician anesthesiologists in a dozen African countries. Zimbabwe, with the richest supply of anesthesiologists in the group, on a per capita basis has 3% the supply of the United States. I vividly recall an event last year at which I introduced one of the inaugural ASA Global Scholars, Dr. Christopher Chanda, and mentioned that he was one of 15 anesthesiologists in Zambia, a nation with a population of more than 16 million. Jaws dropped and eyes popped in every corner of the room. I'm glad that we didn't have a scholar from Ethiopia that year, though we do here in Chicago, where there are 23 anesthesiologists for a population of 99 million. I fear we might have had fatalities at the event if I had shared that statistic. So what do we know about right-sizing the provider workforce? I'll turn once again to the amazing Lancet Commission for an analysis of the specialist physician workforce, by which they mean surgeons, obstetricians, and anesthesiologists, as it relates here to maternal mortality. Alas, not to perioperative mortality, but in view of the earlier discussion of the global state of that metric, you know why. But what we see here is a fairly steep improvement in maternal survival, up to about 40 specialists per 100,000 population. Today, almost half the world's population lives with a specialist density of about half that number, and it will require literally millions more to reach the point at which meaningful improvement in maternal survival, and by extrapolation, perhaps survival from surgical disease, will be seen. Not surprisingly, there is a widespread global interest in bridging the gap in the specialist physician workforce with personnel whose training is shorter and less expensive. This approach has historically been known as task shifting and is part of care delivery in anesthesia, surgery, obstetrics, and nearly every other field of medicine around the world, and is actively and officially promoted by the World Health Organization. The extent of training varies widely from country to country and from discipline to discipline, But there are vanishingly few low or middle income countries where these occupations are not part of the healthcare workforce. In Ethiopia, mentioned previously, the 23 anesthesiologists are supplemented by more than 600 nurse anesthetists. But in many parts of Africa, the anesthesia providers have neither a medical nor a nursing background. The Lancet Commission advocates for maintaining a relationship between the specialist and the non-physician provider. And they stress the distinction between task shifting and task sharing to emphasize a shared responsibility for the outcome of care, advocating for a team-based approach to fortifying the health workforce. Now, considering that commentary, it may come as a surprise to you that there was not a single American anesthesiologist on the commission. Despite this, the task-sharing message articulated by the Commission seems tightly aligned with the message that ASA has promoted in the recent VA healthcare campaign and numerous other scope of practice advocacy efforts over the years. The long-standing and dramatic shortage of an indigenous physician workforce is a major motivator for the enormous volume of work done globally by humanitarian volunteers and non-governmental organizations. Last spring, the World Journal of Surgery carried an inventory of the organizations providing surgical care or education around the world. A whopping 403 groups are involved in this work, and I imagine many of you contribute your time and skill to their missions. If so, you are among some 200,000 Americans who participate in medical volunteer missions annually. Some of the best known names in charity are among their ranks, including Research, Operation Smile, Doctors Without Borders, and others. You'll notice, by the way, that the color shading on the map shows an astonishing variation in the level of NGO activity globally, begging the question of whether this is related to need or evidence of haphazard deployment of volunteer resources. Be that as it may, there is no doubt that the patients treated in these missions and their families derive great benefit, and the volunteers take home a unique kind of enrichment. In many instances, the principal goal of these groups is to whittle away at the 5 billion lacking access to surgical care by increasing the quantity of surgical procedures delivered in low-resource settings. By and large, conclusions about the quality of this care have been based on personal reflection, but happily some of these organizations have recognized the need to become more rigorous about assessing their work overseas, just as we are trying to become more quantitative about our outcomes at home. Médecins Sans Frontières, or Doctors Without Borders, published results from 6 years of data on anesthesia care in its many facilities around the world. Now, I call your attention to this report first and foremost because MSF is making an investment in understanding the quality of their care and deserve our admiration for doing so. The results reported are at the least thought-provoking and are somewhat surprising to me. They find an immediate perioperative mortality rate among their patients of 0.25%, nearly identical to the rate in the low Human Development Index cohort in the Bainbridge report we discussed earlier, and more than 8 times the comparable rate found in our National Clinical Outcomes Registry. I will leave it to another day to explore the meaning of these comparisons that were presented by the authors, but it seems to clearly demonstrate that there are important surprises to be found, and however challenging, there is an obligation to go beyond personal reflection and to measure results. The Anesthesia Quality Institute has an opportunity to provide a platform to disseminate this practice, and I will take this opportunity to agitate for it to make such a contribution to humanitarian surgical care. There is an ample literature on the subject of the broad implications of humanitarian medical volunteerism. One recent book by the medical sociologist Judith Lasker from Lehigh University is a thoughtful critique of what she calls volunteerism, in which she means activities in which the benefits to the volunteer are emphasized. She reports on large-scale surveys and interviews of volunteers and the organizations that sponsor their work. Her most recent project involved interviews of 119 individuals and surveys of 177 sponsor organizations. On the basis of Lasker's discussion, I'd suggest that a good approach is to temporarily put aside the obvious benefits to the volunteer and to the individual patients when assessing the broad impact on the long-term health quality of the community in which the volunteer service is provided. A few good questions to ask relate to the impact of the mission on the health system and on local health professionals. Does your work stimulate or suppress the development of a strong health delivery system? Are you perpetuating dependency on visiting caregivers? Does local support during your mission distract from key functions of the facility in which you are working? Does the participation of visiting staff, especially non-professional support staff, diminish employment opportunities for local residents? And perhaps most importantly, can you point to a feature of the local health system that is reliably and sustainably improved after your return home? These are some of the macro considerations that are important in developing a balanced assessment of humanitarian volunteerism in the long view. Happily, there are many examples of programs that can answer yes to this last question. I want to now consider the difficulties related to the inadequacy of the material resources that are part of our daily work. And I will focus particularly on biomedical technology, but I want to leave no doubt that the simple stuff is an enormous problem too. This table is from a survey of 91 anesthesia providers in Uganda that demonstrates pervasive problems with availability of a reliable supply of electricity, running water, and the most basic of laboratory capability. I have seen similar difficulties in Guatemala, where families were expected to bring a supply of sterile surgical gloves to the hospital for the surgical team and to buy medications at their pharmacy to bring to the hospital. If we believe that the advanced anesthetic care that we deliver depends not only on our skill and training, but the technology available to us, you'll understand that shortcomings in biomedical equipment supply and maintenance will ultimately be a barrier to achieving the standard of care we desire in all settings. Anyone who has visited hospitals in low-income countries will recognize the biomed graveyard pictured here. This is an unforgettable illustration of the problems with donated equipment. And whether new or used, at least 80% of biomedical technology in low-resource settings is donated by organizations or individuals. And an enormous proportion of the equipment donated is so inappropriate for the setting receiving it that no more than 30% is ever put into service. And those devices that are used don't stay useful for long. At any given time, 40% is not functional, and the more complex and sophisticated, the more likely to fail. And device failure is usually a permanent problem. Remember the graveyard, because access to biomedical engineers or technicians is exceptionally rare. Nearly all low-resource settings in Africa have difficulty in acquiring this service, and nearly as many in Latin America and Asia do too. One point is worth emphasizing here, which may seem obvious, but I'm going to state it anyway. Donated medical equipment without skilled maintenance can be worse than useless. Delivering patient care with faulty equipment can put patients at risk of injury or death. And use of unfamiliar equipment without adequate training can pose the same risks. And this is exactly the point emphasized by the APSF a few years ago in a set of recommendations on training derived from one of its consensus workshops. Recognizing the widespread problems and hazards of equipment donation, the World Health Organization has addressed a range of key issues in multiple editions of a guideline on this topic. And I'll highlight two critical messages from the WHO and others on this subject. Amazing as it may seem, donations are often made without prior input from the recipients on needs. So equipment that is valuable in my clinical setting may be completely irrelevant in a very different one. Thus, the finding that more than 2/3 of donated equipment is never used. A fundamental requirement of responsible donation is a two-way conversation about needs and the utility of equipment at its destination. And this is the opportunity to think about the maintenance and training requirements of a device and the local capacity to provide this support. The second message is about a double standard. Simply put, if an item is unacceptable at home, it's unacceptable as a donation. This is kind of the hardware analog of the principle that if you're not qualified to perform a procedure at home, you mustn't be doing it in the context of a service mission. There are, however, some extremely encouraging developments in the area of providing reliable access to medical technology, and let me provide some highlights of two. The first is that a handful of NGOs are investing in the training of a biomedical engineering workforce. So Engineering World Health, based in North Carolina, has now produced nearly 150 biomedical technicians in Rwanda and is duplicating its program in Cambodia, Honduras, Ghana, and Nigeria. The Tropical Health Education Trust will graduate its first class of engineers in Zambia next year. In Uganda, the Almathea Trust has collaborated with a local university to develop a 2-year diploma program. And the collaboration between the American College of Clinical Engineering and the World Health Organization and also the Pan-American Health Organization has spanned decades. In the biomedical engineering world, I think of these programs as analogous to ASA's overseas teaching program that aims to develop a self-propagating faculty of anesthesiologists for low-resource countries. In the meantime, a community of technology innovators has been creating devices specifically designed for use in harsh environments that lack engineering support. The LifeBox oximeter is a leading example of this approach, and it has been joined by others. This story was nicely told in this recent Wall Street Journal article, whose headline, you'll notice, includes the author's observation that success depends on understanding the conditions and resources of the local community. These are some of the developers of biomedical devices for low-resource settings with whom I've become acquainted, and some of us have formed a little club that has been regularly conferring over the last year. While many of these organizations are working outside of surgery and anesthesia, a number in maternal health, it's clear that we all share the same challenges of identifying needs, managing distribution, providing training, and reaching for sustainability. Interesting, the Lancet Commission, about whom we spoke earlier, specifically pointed to a need to collaborate and coordinate among the community of device makers in global health. Though probably unknown and overlooked in the parts of the world where it is most needed, the World Organization has been publishing what amounts to a catalog of such health technology for a number of years, pictured here. A more 21st century approach to connecting the developers of this technology with those in need of it has been appearing in the last couple of years. So the online platforms Maternova, Frontier Health, and Via Global represent the Amazon or Alibaba approach to providing a dynamic resource for NGOs, governments, and healthcare providers to identify and purchase equipment specifically made for their environments. They remind us that all the brilliant design in the world won't help patients if the devices, parts, and supplies are not accessible. And to take this one step further, wouldn't the deployment of drone delivery technology be far more beneficial in the Rift Valley than it is in Silicon Valley? Let me close then by summarizing some key points that I hope you'll take away from our time together. First, the gap in access to essential surgery causes suffering and death, but preventable harm from surgery is also a human tragedy. The need for the triad of people, knowledge, and tools to address these intertwined crises is so desperate in so many places that a role in the solution must be a key element of our professionalism. Second, our generosity is truly an expression of the best in human nature, so it seems inconceivable that we could do harm. But we actually do need to consider the impact of our contributions from both 30 and 30,000 feet. Next, the result, and therefore the merit of the greatest and most obvious improvements is a function of not only the brilliance of the concept, but of the strategy to execute on it. And though worlds apart in this respect, there are many lessons to be shared between the richest and poorest corners of the earth. And finally, amidst all the profound needs to be met in improving health globally, it would be easy to dismiss outcomes measurement as a needless luxury. It isn't. It has been an immense pleasure speaking with you, and I hope I have done something this morning of which Jeep would have approved. Thank you all.
On behalf of APSF and ASA, thank you, Dr. Hannenberg, for an outstanding presentation. I'm confident that Jeep would have been very proud. Thank you to all.